why do we care? Why do we care about colon cancer? Can anybody tell me what these sales flags at the National Capital in DC stand for? This was a display in Washington, D.C. in March 2024, united in blue. Anybody have any idea? Pardon me? Close. Because you answered, I have a little prize for you. This is that kind of talk. Thank you, Jessica. These flags represent 27,400 estimated colorectal cancer diagnoses by 2030 between ages 20 and 49. How many of us have thought that the age of colon cancer screening is just for decades, right? And I just want to start by pointing out the attention here. We are seeing this disease in younger and younger people, all right? So my goal today is to talk about how common colorectal cancer is. What is it, and why should I care? What causes it, and how can it be prevented? And more importantly, what can you do to prevent it? So with that, let me ask you a question. What common cancers can you prevent with screening? Easy. Colorectal. So I want to make a point here. We have screening tests for very common cancers. Breast cancer, colorectal cancer, prostate cancer. But the screening tests detect cancer early so we can treat it. But the one cancer that can be prevented is colorectal cancer. And why it can be prevented, we're going to learn about it. Anybody can name a US president who was affected by colorectal cancer and really helped increase awareness? Ronald Reagan, the 40th president. He was diagnosed in his second term with colorectal cancer. Fortunately, it was an early diagnosis. It was surgically removed, and he did well. But he was instrumental in his time to raise awareness for this disease. So throughout my slides, I'm going to point out and highlight very public figures who have been affected. So colorectal cancer affects the large intestine, which is called the colon. And it's about 5 feet long. The last inches of the large intestine is rectum. And basically the whole reason to care about this colon is it's an instrumental organ in reabsorbing salt and water and storing waste. As my mentor once said, to swallow food and defecate is a common right. It should not be a privilege. So there are a lot of people who suffer from constipation, diarrhea, and it's often not working well. So what is cancer? What is colorectal cancer? It's a growth of normal cells that invade the normal tissue and then can spread into the different parts of the body. Colorectal cancer is the second leading cancer killer in the USA. True or false? Remember, I have prizes. True, yes. Okay. So it's the third most common cancer in both men and women combined. It's the second most common cancer that leads to death in the United States. Very, very important. And that's why we're talking about it. More than 50% of colorectal cancer can be prevented. And the lifetime risk, 1 in 25 women and 1 in 23 women, that men, have a lifetime risk of colorectal cancer. So look around yourself, okay? There are more than 25 people in this room today. Chadwick Boseman, another very popular public figure who unfortunately died of colon cancer at age 43. He had stage 4 cancer that he struggled with. Colorectal cancer often starts with no symptoms. True or false? True. Yeah, very good. But I didn't see who answered first there. So I'll just have just randomly. So this is the most common misconception that I hear from my patients when I'm trying to convince them about screening. They're like, well, I don't really have symptoms. I don't have a family history. Well, the one risk factor that we all have is aging. We are all aging. Right there in this moment, age is an independent risk factor. All of us have a risk of getting colorectal cancer. And if I want you to take away one thing from today, it's that. You don't have to have family history, you don't have to have symptoms. All of us, just like we do maintenance on our cars, this is what we need to do for our own health. More than half of the people diagnosed with colorectal cancer have no symptoms. And what are these symptoms? I have a pictogram here. Blood in stool, change in shape of stool, abdominal cramping and discomfort, prolonged constipation or diarrhea, decrease in appetite, unrestricted weight loss. So if you're having any of those symptoms, please do seek care. That goes without question. But if you're 45 or older, you should talk to your provider about getting colon cancer screening. So as I mentioned, what are the risk factors? Age, independent risk factor, family history, genetics. So if you have family history of colorectal cancer, you're at increased risk of getting cancer. If you have other diseases like inflammatory bowel disease, Crohn's disease, ulcerative colitis, that puts you at high risk. Diabetes puts you at high risk. Alcohol use, obesity. This is a big one that people don't realize because we are a red meat loving state. Red meat consumption actually has been shown to have increased risk of colorectal cancer. Processed meat has been classified as a carcinogen. Smoking, of course. And what are the factors that can help decrease the risk? Well, physical activity. It's a big one. Physical activity and diet high in fruits and vegetables. Both men and women get colorectal cancer. True or false? Okay, somewhere there. She's good morning, good job. That was a very firm truth. That's correct. Even though the risk is pretty much equal, women are less likely to get screened. That's why this is so passionate thing for me, a topic for me. We are caretakers, we are nurturers, we are in charge of our households, and we're taking care of our kids, husband, family members, but we often forget about ourselves. Okay, Oklahoma colon cancer screening rates, we are in the bottom 5 states in United States in terms of screening. Let's get those rates higher. Okay. African Americans are diagnosed with this disease earlier. They have barriers to care, so their treatments are delayed. So we all have to recognize that and do better. Audrey Hepburn is another very, very popular actress who was diagnosed with colon cancer and unfortunately died with it in 1993. And I think this is the last one. You can stop this cancer before it starts. Yes, her. So how do we prevent it? Well, screening tests. Screening. Screening is basically testing to find a disease in people who have absolutely no symptoms. And what are the screening tests? Well, colonoscopy, colon stool testing, like Cologuard fit testing. And I want to talk about colonoscopy a little bit and what colon polyps are. Polyp is a growth of tissue, just like a mole outside on the skin that can grow into cancer. It's a tissue like this, the growth, that has the potential of turning into cancer. There are 2 types of polyps: hyperplastic, very, very benign, very small chance for advancing into cancer; adenomatous polyps, which are the ones that can turn into cancer.
So by removing these, we effectively prevent colorectal cancer. So let's talk about colonoscopy, the dreaded colonoscopy. Out of curiosity, how many of you have undergone that procedure here? Hey, these are my people. This is amazing. So, so what we do is when you're nice and sedated, we don't want to torture you. We take this thin scope, and it is a thin scope, and we go all the way to the end of the colon. And what I'm looking for are polyps, any other lesions, diverticulosis, inflammatory bowel disease, and most of the polyps can be removed endoscopically. And you go home within, an hour or two of this procedure. Screening saves lives. Age 45. 45 is the new 50. I want to point out this is this is the big question I get asked. What is the difference between stool testing and screening and colonoscopy? Well, there's one-step test. This is the best way I can explain it. One-step test versus two-step test. So the best screening is the one you get. So, if somebody is like, I'm not going to go for colonoscopy, sure. Go get your Cologuard. Go get your fit testing because I want you straight. But once you get the stool testing done and it comes back positive, then you have to undergo colonoscopy. So it's a two-step to be able to, get kind of the peace of mind that you're polyp-free, colon cancer-free. One step with colonoscopy, we're looking for polyps, we're looking for other lesions, we're looking for other types of cancer that are non-adenomatous, like neuroendocrine tumors. So lots of different benefits for colonoscopy, but that's the best way I can explain. One step versus two step. But remember, if you have a stubborn family member who's like, don't you dare talk to me about colonoscopy, get them to do a stool test, okay? But remember, the stool testing is only for average risk people, okay? Not somebody who has family history of colon cancer, not somebody who has family history or personal history of IBD. So like I said, 45 is the new 50. So how do we prevent cancer? Just to review, get screened, 150 minutes of physical activity per week, plenty of fruits and vegetables. We have some great charcuterie board there. Get yourself some. And limit alcohol and red meat consumption. Keep calm and schedule your colonoscopy already. And this is, I know I'm probably over the time, but basically get screened. So thank you.
All right, guys, it's time to talk about breast screening. I'm Dr. Anna Stidham. I'll be talking to you today about breast cancer and what you can do to prevent it. And yes, we haven't gotten to the point where we can absolutely prevent it like colon cancer. We can't take things out that might turn into it because the imaging just isn't quite there yet. And it's so heterogeneous. It can look like a normal tissue. So a little bit trickier there with that one. But our mission here at Premier Breast Health Institute is to detect early, streamline the process for care and treatment. And we feel like we have a good blend of advanced technology and compassionate care here. And so these are the objectives I want you to kind of keep in mind as I'm talking. And so I'm going to talk about how common breast cancer is in our community. The 4 breast self-awareness messages that I want you to take home and kind of one action plan for each one. One resource for breast cancer information, some common risk factors, and also I want you to share something that you learned at this talk with somebody that you care about. So how common is breast cancer? So in women, it's the most common invasive cancer. It's the second main cause of death after lung cancer in women. Different than combining male and women. So if we're just looking at women there, it's quite common. 1 in 8. And women in their 40s, it's 1 in 6. So it's pretty common. But the good news is that early detection does save lives. Breast cancer death rate have declined at least 42% during this time frame that has been measured. And most of the time, if we catch it in the early stages, treatment is effective and it offers the best chance of survival, 95 to 99% chance of basically almost a cure. But we can't cure aging yet, so that's there. So some of the breast self-awareness messages that I want you to take home with you: know your risk, get screened just like colon cancer screening, know what is normal for you, and then make healthy lifestyle choices. That's going to be the theme throughout here. So those healthy lifestyle choices are really big. So about your risk. So 90 to 95% of cancer is not associated with family history. So just know that you're not in the clear just because, oh, no one in my family's had breast cancer. It can just arise de novo. But so anyway, talk to both sides of your family because there are some forms of cancer that are associated with breast cancer, like some forms of prostate cancer, some forms of colon cancer, some forms of pancreatic cancer. They're a related gene that can also be a breast cancer gene. So talk to your family members, get a good history from both sides, and then talk to your kids because, that's super important. Talk to your doctor about what personal risks you might have and what you can do to prevent and to decrease your risk. So here's some risk factors and risk reductions. So first thing to know is that risk factors don't cause breast cancer, they're just associated. Okay, so it's just like any other risk for anything else. They're just associated with an increased chance. Some can be controlled and some cannot. And here are the two most common risk factors: being born female and aging. Can't control those. We're stuck. But there's some other risk factors here that you can control over to the right side of the chart here. Here again, these are the two most common: being born female, getting older, inherited genetic mutations, and then some types of tissue that you might have biopsy that comes back with certain types of names like atypia and lobular carcinoma in situ, which is not a breast cancer, but it's a marker for increased risk. Family history, of course, tied to inherited genetic mutation. Dense breasts. So dense breasts are not how they feel, but how we see them on a mammogram. So when we image the breast with a mammogram, you have whites, grays, and blacks, different shades. When your breast tissue is dense, there's a lot of white. Well, guess what cancer looks like? White. So when you have a lot of white, it's like trying to find a snowflake in a snowstorm. It can be quite tricky. Even with the advancements in 3D and the resolution of our monitors, it's still, when you have dense breasts, there's still a 30 to 40% chance that we will not see an early cancer with just mammogram. Mammogram is important though because it does detect some cancers that other modalities cannot detect. And I can talk to you all more about that individually if you have questions. So high blood estrogen levels, we can't really control that, but one thing we can control is postmenopausal weight gain. So from the age of 18, if you gain, this is going to be really depressing, but if you gain 20 pounds from the age of 18, your risk actually goes up because our fat cells actually convert inactive estrogen to active estrogen. So obesity you have more estrogen with obesity. So estrogen levels are a risk factor. Obviously, previous personal breast cancer, no children or first child after age 35, and not breastfeeding are because the breast tissue goes through different differentiation. The cells learn what to do when you have a child, and they learn what to do when you're nursing. But when you don't do that, they're kind of like, hey, I'm going to do whatever I want. I'm going to secrete this. I'm going to make fluid. They don't really know what they're supposed to do. So your chances of cancer can increase slightly without those two. So those are protective. Drinking alcohol, just like colon cancer, smoking, and then no physical activity. So get moving. So get screened. Talk with your doctor about what screening tests are right for you. And if you are at higher risk. If you're not at higher risk, then the age is 40 here. 40 to start your annual screening mammograms every year, because Studies have shown that if you skip a year, there's like 55% chance that we're going to miss a cancer that might have happened in that time interval that we could have caught earlier. Clinical breast exams are back in fashion every 1 to 3 years starting at age 20 and every year starting at age 40. So go see your gynecologist, even if you're not having a pap smear. And then you can sign up for screening reminders also at komen.org, and they'll actually email you when it's time. So that is another way of keeping track. Or you can do it annually on your birthday, or same day or same holiday. Pick a holiday. So mammograms in the U.S. are the best screening tool available because it has been the one modality that has shown decreased death rates. It can be used as a diagnostic tool. Clinical breast exams are important. Know what's normal for you. So here are some signs. They're not all associated with cancer all the time, but here are some signs that you need to be looking out for. Of course, a lump or a hard knot or a thickening in your breast, swelling or warmth or darkening of the breast. Breast cancer can look like an infection, so always get that checked out. If you're going to antibiotics and it doesn't resolve, definitely go get it checked out. Change in the size or the shape of your breast. This is a sudden change. All women are asymmetric, but a sudden change without association with weight gain or weight loss is something to be concerned about. Dimpling or puckering in of your skin. Sometimes the cancer can start pooling on tissue, and that's the way it can appear. Itchy, scaly, or sore rash on your nipple. Some forms of breast cancer just happen in the nipple. Pooling in of your nipple or other parts of the breast. Again, just like that skin dimpling action, if it's new and if it doesn't resolve with stimulation. Nipple discharge that starts suddenly, or a new pain in a new spot that doesn't go away. Here are the healthy lifestyle choices you've already heard about. Limit alcohol intake. 1 drink a day isn't going to get you there. It's dose dependent, so it's the excessive alcohol. Exercise, maintain a healthy weight. Breastfeed if you can, limit postmenopausal hormone use, and here's your review screen. I've been told that I'm past my time, so we'll answer questions at the panel. Thank you.
Good morning, everybody. My name is Pranathi. I'm a dermatologist. I work in Edmond. It's a pleasure to be here to talk about skin cancer. It turns out May is Skin Cancer Awareness Month, so this timing is perfect. I'm going to get started with a question for the audience. I didn't have the foresight to bring t-shirts, so we'll be, oh yeah, there's a gift bag. Thank you. So can anyone tell me what Bob Marley, Hugh Jackman, Khloe Kardashian, and Nora O'Donnell all have in common? Skin cancer, yes. Can someone tell me which skin cancer they've all had in common? Very good, yes. I don't know, a lot of people had it right. So they've all had melanoma, and I'm going to start the talk with a conversation about melanoma. There are 3 most common skin cancers. This is the most dangerous of the 3. So we're going to focus on this first. What is melanoma? I think there's a lot of confusion about that. We have a lot of patients come for their skin checks and they say, my mom has had a melanoma or my grandpa had a melanoma. And then when we ask more questions, they'll say it was burned off their skin. And that's an immediate, kind of clue that it was probably not melanoma. So we're going to look at this picture for just a few seconds. And this is a cross section of the skin. This topmost layer is like frosting on a cake. This is the epidermis. And this is where the 3 most common skin cancers arise. So we're looking at this little sliver at the top, and this is a close-up view of that sliver. So if you look along this lower layer, there's a special cell called a melanocyte. It's in blue. A melanocyte is a cell that produces pigment called melanin, and melanoma is a cancer of the melanocyte. So it's a special cell that produces pigment, and when it proliferates abnormally, you have a melanoma. There will be an estimated almost 250,000 cases of melanoma this year in the United States alone, and that's not accounting for worldwide. There's a very high incidence of melanoma in Australia, New Zealand, other countries. So what are the risk factors? Skin type is a big risk factor. Having fair complexion, especially fair complexion with red hair, a tendency to freckle, a tendency to sunburn easily. That is the skin type that we are most concerned about. Having said that, any skin type can develop skin cancer. So I don't want anyone to leave here with the misunderstanding that if you're not a redhead with fair skin that you cannot develop skin cancer. But that's a uniquely susceptible population. Sunburns are very damaging to the DNA of all of our skin cells. Having more than 5 sunburns, they don't have to be blistering, but blistering ones are especially problematic. They are especially problematic if they happen before you were 20 years old. So preventing a blistering sunburn in a child at 8 years old significantly reduces their risk for melanoma in the future. So we always screen for that. 5 or more sunburns at any point in your life doubles your risk for a melanoma. I have Hugh Jackman here because he's Australian, and in Australia, the intensity of their ultraviolet radiation is very high. So it's a very high incidence of melanoma in that part of the world. Tanning beds are a huge risk factor. Tanning beds are banned in Australia, Japan, and Iran. I didn't think that was a country that would have tanning beds, but they're banned. Tanning beds are classified as a class 1 radiation risk, along with cigarettes and plutonium by the World Health Organization. Any tanning bed exposure in your life will increase your risk for all skin cancers and melanoma in particular. And the more times you've used a tanning bed, obviously it's a dose-dependent risk. So it is something that must be, it's a practice that has to be terminated. And Khloe Kardashian has used tanning beds. Immunosuppression. Immunosuppression can be from having received chemotherapy for cancer, having an autoimmune illness like lupus, where you took medications to suppress your immunity. Also, organ transplant and stem cell transplant patients are uniquely susceptible to skin cancer from their anti-rejection medications. So they have to have regular screenings. Patients with chronic lymphocytic leukemia, which is an indolent hematologic malignancy, are immunosuppressed as well. So that's a risk factor for all skin cancers, including melanoma. Also, what does your skin look like? Do you have a lot of moles? Do you have more than 25 moles? What do your moles look like? Are they large moles? Are they all sorts of shapes and colors and sizes? Are they very diverse? That is an additional risk factor. There's a misconception that removing every mole or taking off all the moles you don't like on your skin would somehow decrease your risk. That is not the case. 70% of melanoma arises on normal skin. It is not a pre-existing mole. 30% of melanomas do arise from a pre-existing mole. So you have to watch your moles, be familiar with where they are, what they look like, watch for changes, but most importantly, watch for something new or unusual that pops up. Skin cancer history. So patients who've had multiple basal cells, squamous cells, their risk for a melanoma is higher. And lastly, family history plays a larger role in your risk for melanoma than it does for the other skin cancers. So there are certain genetic syndromes that have a higher associated risk. If you have a BRCA2 positive mutation, your risk for melanoma is higher. CDKN2A is another mutation that increases your risk for breast, colon, and melanoma. And if you have a first-degree relative who's had a melanoma, your risk is much higher. So know your family history precisely. Is it because there's so many people that come in with that family history, and we just sometimes don't know if it's a real melanoma. So you just want to know, make sure that that risk is well understood. First-degree relatives, parents, sibling, or child can increase your risk. So this is what everyone knows, the A, B, C, D, E's of melanoma. Very quickly, asymmetric, both sides don't match each other. An irregular border, multiple colors, large diameter, and E is for evolving, which is something changing. But I want you to take away a different sign today, which is the ugly duckling sign. How many of you have heard of an ugly duckling sign? Has anybody heard of it except for Carrie, my MA, who's here? Who hears this 20 times a day? So ugly duckling sign is the takeaway. So what is an ugly duckling? It's the spot on you that's different than the others. It doesn't have to be the larger one. It doesn't have to be the darkest one. It has to be the odd ball. And we'll look at some examples in a second, but that's the sign of either a melanoma or a severely atypical mole. So now we're going to go into the clinic and look at some cases of melanoma that we've biopsied. And this is, I showed this image to show, this is the instrument we use to screen for skin cancer. It's called a dermatoscope, and it's just a magnified lens with the bright LED light. A lot of patients think it'll light up a skin cancer, and that's how I know it's like a metal detector. If only it were that easy. It's not. Okay, so this is an example of a melanoma on the leg. Legs are the most common place, the buttocks and legs are the most common place for melanomas in women. Because unlike the other skin cancers, melanomas show up on parts of our body that have been exposed to intermittent high doses of ultraviolet radiation. So legs are usually covered up, but they get exposed in the summertime, skirts, shorts, bathing suits. For men, it's their back or their torso in general. The shirt comes off, they're mowing their lawn, they're on the beach. So these places that are always exposed are more commonly affected. So you can see this spot on the leg under the dermoscopy. It's an irregular brown macule. Here's a spot on the back of the ear. Just looks like a darker freckle, but we use our dermoscopy clues to kind of distinguish it. And we did a biopsy, and this was also melanoma. This is a spot on the bottom of the foot. For the longest time, she thought it was a pebble that created some type of bruise or injury. It kept changing, and this turned out to be an invasive melanoma on the bottom of the foot. So this is a great picture of a melanoma hiding amongst the barnacles that grow on older folks. So these dark, crusty, harmless skin tag type lesions, and there's some melanoma within that cluster. This is a great example of an ugly duckling, a very small spot on the leg, and this was early melanoma. There was nothing else like this on any part of her body. This is a classic melanoma on the back. This was a woman who's a construction worker, actually. Another type of melanoma is called lentigo maligna melanoma. These are more common on sun-exposed surfaces like the head and neck, and they're indolent and slow growing. And this looks like a small freckle that starts to grow in size. This is on the back of the arm, and this is on the upper arm, just a classic melanoma. Here's an example of an invasive melanoma. He was a landscaper. He came in with this nodule that was growing rapidly. It was removed. There's a skin graft, and a few months later, there was a recurrence nearby. Acrolentiginous is melanoma on the palms and soles or the nail unit. It disproportionately affects persons of color, and Bob Marley died from this at 36. He thought it was a soccer injury. What determines the prognosis? How deep it goes. So the earlier you catch melanoma, the better the prognosis. The deeper it goes, the more likely for it to go to lymph nodes. So treatment, you cut it out. You might need a sentinel lymph node biopsy. Lots of new therapies for advanced melanomas. PET scans can show distant metastases. 99% survive in 5 years if it's detected early. So we're going to move on to the most common skin cancer, which is basal cell. 3.6 million people are diagnosed with that yearly. Again, looking at this picture, you can see basal cells are also in the epidermis. They're at that bottom layer of skin. I'm sorry. I'm trying to go as fast as I can. Oh, okay. So basal cells look like a crusty spot, a pimple that won't go away, a sore that won't go away, and these are on sun-exposed surfaces. This was a morpheaform basal cell, looks like a scar, and this is on the back of the ear. A very common presentation, ulcerated nodule. The nose, the bottom third of the nose is the most common place for this. It can be pigmented. This was a dark basal cell. It can look like a scaly patch of eczema on the back or the arm. Classic presentation on the forehead. And we look at close-up. This little tortuous blood vessel is our telltale sign it's a basal cell. But basal cells, very common. They're curable. No one really dies from a basal cell unless it's very it's advanced, but they can be locally destructive. So they have to be taken seriously. Um, Squamous cell, I'm going to talk about in the same context. It's the second most common skin cancer. 1.8 million people are diagnosed. Squamous cells are different from basal cells or melanocytes, and they often present as precancerous patches called actinic keratoses. Those are crusty red spots on sun-exposed skin. 58 million people have these, and they're treated with liquid nitrogen, and they're prevented with sunscreen. So squamous cells look crustier. They look like warts sometimes. Always sun-exposed surfaces are preferentially affected. Here's some advanced squamous cell carcinomas that look like very large, crusty nodules. Risk factors are slightly different. 50 plus, men more commonly get squamous cell carcinomas, but that's changing. Women are getting more. Sunburns, tanning bed exposure, immunosuppression, skin cancer history, and skin type. In an organ transplant recipient, 100 times more common to get squamous cell carcinoma. So how are these non-melanoma skin cancers treated? I'm sure some of you have heard of Mohs surgery. This is local, done under a local anesthetic. It's staged excision. So the surgeon removes a sliver of skin, checks under the microscope to make sure all the skin cancer cells are removed. And this is done for non-melanoma skin cancers in specialized places, like the scalp, face, ears, hands, functionally and cosmetically sensitive areas where you don't want to take a big chunk of skin out. So that is the standard of care. If it's on the back or arms, you can have an excision. They can even be scraped or treated with a cream if they're superficial. 99% cure with Mohs. Merkel cell, Jimmy Buffett brought this to everyone's attention. It's rare, but it's aggressive. It's 3,000 cases per year. It's usually an asymptomatic nodule that's growing rapidly. It's men usually that are affected, older than 50, lots of sun exposure or any immunosuppression. This was a case we had in clinic of a Merkel cell that grew explosively over a 6-month period because it was not treated. They deferred treatment because of her dementia. Okay, prevention. So sunscreen is key. Everyone asks in clinic, what is the best sunscreen? It's the one that you're willing to wear every day. The SPF has to be at least a 30. We apply if you're sweating or swimming. And don't underestimate shade, staying out of the sun between 10 and 4 when the UV is at its most intense, protecting children from getting sunburned, and reapplying sunscreen throughout the day is very important. And then if you're near water, on the beach, snow, skiing, your UV is amplified in those environments. You have to be more careful. What about vitamin D? Do not get it from the sun. Get it from your diet, get it from your supplement, and avoid tanning beds at all costs. How to spot? Check yourself monthly. Become aware of your moles and have your hairdresser check your scalp. Check yourself thoroughly and be vigilant for anything new or changing. When should you get a skin check? How young? It depends on your individual risk. Unlike breast and colon and cervical cancer, there are no guidelines about when to start that screening process. So the risk factors we talked about, if any of those apply to you, have a baseline skin check done with a board-certified dermatologist to establish that risk. This is Spectrum Dermatology in Edmond. We'll have a location in Nichols Hills in a few months. We have an all-female cast and crew, and everyone's wonderful. My nurse Carrie is here. We've seen thousands of patients together and done a lot of these biopsies together. So it's a wonderful place to work. You're welcome to come see us, and happy Mother's Day to everybody. Thank you.
I was really happy that they asked me to talk about cervical cancer screening because it's not as glamorous and it's very common. We, a lot like colon cancer screening, we do have a really great screening tool that can prevent cervical cancer from happening, and that's what the pap smear is. So this annual exam that everybody dreads doing is not just an exercise in female embarrassment. It is to keep you safe and healthy. They do recommend that you have an annual exam once a year. We don't always do a pap smear every year. I guess I should back up actually and tell you that your cervix is the bottom part of your uterus. It's like the opening of the uterus. And those cells within the cervix are prone to grow quickly and turn over quickly. And so that's why they're a little bit more likely to develop cervical or more likely to develop cancer than other cells. Cervical cancer is unique in that almost all cases come from infection with a virus called the human papillomavirus, HPV. That is a sexually transmitted virus, and it's very, very common. Most people who have had sex have probably been exposed to it. It infects those cells of the cervix and causes them to grow abnormally in ways that can go on to lead to cancer. The good news is that most people have healthy immune systems and can suppress the virus and heal those cells and return them to normal. But we don't know who is going to suppress the virus and heal their cells and who will go on to develop cervical cancer. So during your annual exam, we do what's called a pelvic exam, where we use a tool to look inside your vagina and see the cervix. There are some cancers that are fast growing, and that's how we detect them, is that visual survey. But most cancers are pretty slow growing. It takes most people about 10 to 20 years to go from the pre-cancer cells to actually developing cancer. And we detect that by doing the pap smear that everybody kind of knows about. We use a thin, flexible little brush to sort of sweep those cells away from the cervix, and we send them off to a pathologist who looks at them under a microscope. The pathologist is able to see some abnormal growth and changes in the cells and their behavior and their shape, and determine that, okay, this is a precancer, what we call dysplasia. They're also able to do testing for the human papillomavirus. They look for some of the most common and aggressive strains, and that tells us what your risk of developing cervical cancer is. If we find that you have an abnormality or that you tested positive for HPV, there's some further testing we can do, and sometimes we even remove those abnormal cells and keep people from getting cervical cancer. We used to do cervical cancer screening every year. You turn 18, you get your first pap smear, and you're supposed to go every year until you die or you will die. And that was like a really powerful message, and it's really hard to move away from that. Not too long ago, I think about 10 years ago, there was a group that sort of looked at cervical cancer and how it behaves and how it progresses, and tried to make some changes to how often we do these tests, because while we detect early stages, most of those don't go on to lead to cancer. So finding these abnormalities resulted in some people getting procedures that they never needed, and they're painful and it's stressful. So they kind of came up with an ideal interval for how often we should do the cervical cancer screening. It starts at age 21. We don't do them earlier anymore because a lot of people in their younger years have HPV and will be able to suppress it and maybe never even know about it. You suppress it to undetectable levels and it doesn't cause a problem for you. So we wait until age 21 to do that first pap smear. And in your 20s, you get a pap smear every 3 years as long as your paps are normal. When I say pap smear, I mean that we take the cells, the pathologists look at them under the microscope. In your 30s, we start to do testing for HPV as well as looking at the cells. And that kind of helps us gauge your risk. If your cervical cells are normal and your HPV testing is negative, you actually get a pap smear every 5 years. Now, they do still recommend coming to see your PCP or your gynecologist once a year. We do breast exams and we screen for other types of cancers, but you only get the pap every 5 years in your 30s, along with HPV testing. And then we continue those until age 65. And if you've always had normal pap smears, you've been regular about showing up for your exams, the chances that you will get cervical cancer after that point are low enough that you don't have to do the pap smear anymore. They do still recommend seeing a doctor once a year and having a pelvic exam because there are other things that we screen for as well. But that's always a relief to some people, except for those of us who got that message that you have to do it every year or you'll die. It's a little stressful. So there are some risk factors for cervical cancer. The main risk factor is exposure to HPV, which most people are exposed at some point in their life. But there is a vaccine that was developed about, I'm trying to think, I was in medical school like 13 years ago, 14 years ago, that can prevent the 9 most common and aggressive strains of HPV. And I think with time, and as we get more people on board for the vaccination, we'll see less and less of these abnormal pap smears and cervical cancer throughout the world, and certainly the United States. It is approved for people from age 9 until 45. kind of the ideal time to have the vaccine administered is right before the initiation of sexual activity. So they recommend it now between 11 and 13 years old. If you have kids who see their pediatrician, they may recommend that around that age. Also, if you are a smoker, that suppresses your immune system and makes it more likely that you may not be able to clear the HPV. So we recommend stopping smoking. And then things you can't really control are immunocompromised, which is so many cancers. I think everybody mentioned that. People with AIDS, and so people who have those increased risks are supposed to patch every year. So HIV positive, if you are on an immunosuppressant medication, and not if you're a smoker, but you should just stop smoking. So that's all.
Okay, well, I want to say thank you to all four of you lovely doctors. So I think screening is so important and it's something that we need to focus on and don't necessarily pay enough attention to. So a couple of different things. Screening is, you don't have to have a referral from your doctor to be screened. So if you need a screening mammogram, you can call a breast center, call here, we can schedule it. If you need a colonoscopy, you can schedule that with your GI doctor. So all of their cards and information are up here. Most of you have cards and information in your bags. We're going to do a short panel session, like 3 questions with you guys, and then they're all going to be around. So you're welcome to just stop and visit, ask questions. I think we've got some sunscreen over here, little samples of sunscreen in a bowl. So if you need some sunscreen or you want to try something, then stop and pick some up. So we'll do like 3 questions. Anybody in particular have a question? There's a gift bag for questions. See? Any questions for these ladies? Okay, I'm going to walk back here. It is a long walk. I didn't process that.
So I have a family history of pancreatic cancer, and I see a lot of screenings for so many types of cancer, but not pancreatic cancer. My mother and my grandmother, her mother, died of pancreatic cancer. And so when I asked my family doctor, about this and what can I do, she basically said, there's just no screening for it. Sorry. And so I'm concerned and curious as to what you guys have to say about that.
For bringing that up. That's something we struggle with. So screening tests, as we mentioned, are tests that are for early detection, and it has to show benefit. Pancreatic cancer is very rare, and to the best of my knowledge, we don't have a screening test yet. However, advocating for yourself, sharing your family history is extremely important, and I would recommend, meeting with a genetic counselor because the genetic counselor can help map out your family history. There are some blood tests like SPINK1, PRSS1 as well that test specifically genetically for pancreatic cancer. I have some patients who come to me and ask the same question. So I set them up with a genetic counselor to get that genetic testing. And then, it even though the imaging is not necessarily approved, we have a discussion regarding let's get a CT with pancreatic protocol at baseline just to have some baseline to start with. Again, these are not guidelines because there is no screening protocol, but a genetic testing is, from my perspective, very important because other syndromes like Lynch syndrome, which is HNPCC, can affect other organs too. So my advice would be meeting with a genetic counselor, and I believe we have one.
So we definitely have a genetic counselor here, and there's some little cards around. And if there's a QR code on the card, if you scan it and you answer the questions, it will tell you whether you qualify for genetic testing, whether that's breast, ovarian, pancreatic, and it will send a link to our genetic counselor, and she'll know that she needs to call you to set up an appointment. So those cards, there may be some in your bags, but we've got them all around. So that's something that was real important to us in all this.
You're welcome. I am so glad you asked that question because that's not people don't know about that. So
Another, you have a question on?
So I had a partial hysterectomy
at 40 is emergent, but I did not have an oophorectomy. So now I'm 65. Do I need to worry about my ovaries, or are those like raisins now?
They do tend to raisin with time. They that is part of why they still recommend doing that annual exam. And after the age of 65, it's a little tricky because sometimes Medicare won't pay for a yearly exam. My personal approach to that is to try to find a problem to talk about, so we can kind of bill for the problem one year and the annual the other year. It would still be recommended that you have a yearly exam to evaluate your ovaries and to talk to you about symptoms that could be ovarian cancer. We also still do the pelvic exam because with age, it's more common to have cancers of the vaginal tissue and the vulva. So I didn't exactly answer your question. I will say ovarian cancer is very rare. It's not a common cancer. So there's no screening for it. Pretty much. And actually, it's a pretty poor test for actually detecting early ovarian cancer. We're not very good at it yet. That's all we have.
Okay, one more question.
Hi. What is the limitation of Cologuard?
Yes, so Cologuard, the stool test. There are two big Cologuard. Cologuard is DNA test, stool DNA test, and now there is ColoSense, which is a multi-target RNA test. These two tests, the whole job is you package your stool, you send it off, and what they're detecting is either DNA or RNA, and that's shedded from the cancer that could have developed. So that's what they're testing, and they're testing adenoma cells in the stool. So going back to the first step, one step and two step that I talked about, that's really, really important because the benefits of stool testing is accessibility. People can do it at home. They don't have to worry about the prep and coming in and getting a colonoscopy. The downsides, there are two main ones in my opinion and in the GI community. One is the sensitivity and specificity. So they're very sensitive in testing for colorectal cancer. They're not as sensitive in picking up advanced adenomas or early adenomas in the polyp. And that's a very important point. So the sensitivity is good for cancer. It's moderate for adenomas, but specificity is low. What does that mean? That if it is positive, does that mean you definitely have cancer or polyp? No, you tend to have a lot of false positives. So the number of times I'm getting texts from my colleagues, please get my patient in because they had a positive Cologuard and they're very anxious, is very, very high. Because once you get a positive Cologuard, you Google and you just cannot sleep, understandably so. So that's the big.
Thank you, ladies, very much. So we're going to wrap up and take a break.